practically in our modern era, you hear the word steroid, you think anabolic steroids. For mineralocorticoids, they're going to be managing things like blood pressure, glucocorticoids, inflammation, and sugar levels. Anabolic androgenic steroids, myogenesis, and the growth of muscular tissue.
This is the Man Up Podcast, the doctor's guide to men's health. Each week on our podcast, we discuss various topics in men's health. If you have questions that you're too afraid to ask, we have the answers. This week, our episode is titled Juiced Up, talking anabolic steroids. I'm Dr. Kevin Chu, and I'm joined as always by my co-host, Dr. Justin Dubin. Justin, that was a great Super Bowl we watched this past, was it last week? Yeah.
Was that 2 weeks ago?
Sorry, 2 weeks ago. 2 weeks ago.
Yeah. We predicted, both of us correctly, that Kansas City would win.
That's correct.
Easy money, baby. Easy money. Easiest money I ever made in my life. But it was a good Super Bowl. Weird start, great ending. Can't complain, a little bit too long. But you can never bet against Patrick Mahomes. That's what I said from the beginning.
And you got to know the overtime rules. You got to know the
overtime rules, which was very confusing to me as well. I didn't understand it. But once I did, then I understood that what they were doing was very dumb, San Francisco. So
yeah, towards the end of that, when they weren't rushing towards the end, when they did eventually score a touchdown at the end of the first overtime, I was getting a little nervous. I was like, oh, the Chiefs know that they kind of hustle, but I guess they understood, that there's a second quarter coming along afterwards. So
very weird, but I think it's a good overtime rule. I just think overtime should always be college football. College football is the best overtime rule.
The best.
I don't understand why it's done any other way.
I guess the argument is that the defense is semi-devalued because you're putting them straight on the 35-yard line or whatever.
No, I would say that the kickers are just guaranteed. So you're always going to get someone, but someone's going to miss a point. Someone's going to miss something. And then I think you can't take field goals anymore. There's going to be a point. Like if you both go back and back field goals 2 times, you should just not be allowed to do field goals anymore.
That's true. You got to go for the fourth down no matter what.
Right. Exactly. And that would be awesome. And that would be the best way to do it. But who knows? Who knows? We'll see. Right now, Chiefs are the champs. No question about it. Never had a doubt.
It's going to be some time before football comes back. Basketball, I guess.
Basketball regular season is so bad. No one cares. It's just awful. And it's so crazy because I love playoff basketball. NBA basketball is so damn good. We got March Madness, though, coming up. Which, reminder, everyone get a vasectomy around that time. Book your vasectomies with me and Kevin. We're happy to help you out and take your time off and watch March Madness.
Absolutely.
But, other than that, it's time to kind of just hang out. I have my Sundays free. I might read a book. Who knows? That would be great. Book. Yeah. There's a series called Red Rising that I've been wanting to read. So I heard it's really good. So I think I'm probably going to go into the sci-fi genre for a bit.
Awesome. I'm still trying to wade my way through Dr. Peter Attia's book. It's been very good. Maybe we can discuss it in some future episodes. But
that would be a good idea. Maybe I'll read. I have it. I own it. I just haven't read it yet. So
very interesting concepts, longevity, health span. So I think a lot of stuff that I'm sure our listeners would love to kind of listen about as well.
Yeah. And I think it's always cool to have our opinions on that kind of stuff too.
Absolutely. Now, this episode that we have today is one of our first feature episodes that we recorded live when we were in San Diego together at the last SMSNA meeting, Sexual Medicine and Society North America meeting. And we were joined by one of our good friends, right, Justin? And we had a live and great, interesting conversation on anabolic steroids.
Yeah, so Dr. Alex Tatum, he is a urologist, director of men's health at Urology of Indiana, and he's the corporate director of men's health at US Urology Partners. He has a very, very big, thriving, successful men's health practice. He is a very, very knowledgeable guy on, when it comes to sexual medicine, men's health, testosterone, fertility. And we brought him on to talk about a topic that I think even Kevin and I admit, anabolic steroids. And when we're talking about anabolic steroids, we're not talking about testosterone, which is an anabolic steroid, we're talking about more of the the illegal
The
ones,
level up, man.
the level up ones, Winstrol, Nandrolone, all those, Deca, like obviously Nandrolone is Deca, but you get the point. So, obviously we have an idea of them, but more and more I'm seeing guys come in, whether they've been on them in the past or they're currently on them, and it's something that is not sustainable for them. And a lot of these guys understand that. And I thought we really thought it would be a really interesting episode to have, a conversation about them, because even though they're illegal, I think it's a lot of people are using them, and they're not aware of the real risks. Just as we've established that people don't know the risks of taking testosterone, these are way less regulated and way
Right.
more potentially dangerous. And it's important that guys actually have an understanding of what they're doing and what they're taking. And education is part of that.
Justin, you're absolutely correct. I have more and more patients that come in and kind of mention like, hey, yeah, like a year ago, kind of off, off the market, I was able to get, some of this Deca, and I gave it a try. And, as men's health specialists, we, like you said, we deal a lot with testosterone therapy. We use clomided HCG on the fertility side to try to help boost endogenous testosterone. But when it comes to these medications, as you'll hear in the conversation, I myself am not very, well versed in this. So I learned a ton from Dr. Tatum, and and like Justin said, it's very important for our listeners to understand the risks associated with these very unregulated medications.
Right. And I think it's just, and people may say, like, why are you having an episode on drugs that you don't, give, or, that are illegal? And I think exactly what we've been saying is because most people don't really know, because there is some data on it. There's some data on humans, but a lot of it is really hearsay. There's data on horses, because some of this shit is actually like horse steroids. But once again, if you're a doctor and you care about your patients and you want to know what's best for your patients, I obviously, people have autonomy, and you got to be dumb if you're going to say my patients are just going to listen to whatever I say. They're not going to do these things. But at least if we can educate them on why they shouldn't do these things, or what happens when you do these things, I think that there's a lot of value in that. So, it is
I
important.
thought you were about to go the way about like, to really be a good doctor to understand, Kevin and I are both currently on Deca.
Oh,
I thought
man.
that's
Nah, man. I mean, I don't take anything. I'm natty, baby. And if you look at me, I'm natty. I'm the most natty looking guy ever. You're definitely natty.
oh yeah. You want to? Hey man, the dad
But
bod is not a good representation of Winstrol use, or trim
yes,
use.
correct. Yeah, I'm not a guy who looks like they have they take trend, but we do cover all of these kinds of medications. We cover the risks. We, cover about stacking. We cover about cycling. We cover about the side effects. We explain kind of steroids, what they are, anabolic versus corticosteroids. So this is a really good refresher for people who kind of want to understand the difference between certain steroids, why an anabolic steroid is an anabolic steroid versus a corticosteroid. So, we do kind of get in the weeds here, but I think that sometimes you need to get into the weeds. And I think we do get a little bit more into the weeds here, but that's fine, because I think the people who are interested in this kind of stuff are probably the people who want us to get into the weeds.
Absolutely. But, on top of that, it was just awesome. It was fun. We were in the same room together. It was a live episode, great energy, and it was just an absolutely fun discussion.
Yeah, it's a great point. I mean, being in recording together is always much better. Tatum is awesome. He's funny, and we just get the energy. You can feel the energy in this episode. And we got a couple more that we recorded that we're going to be releasing as well. But I think the camera quality came out great. The shots came out good. The audio came out great. So I think you guys are really going to enjoy this episode. And I think that's all I got to say. What about you?
I agree, man. Let's get into the episode. Enjoy, guys.
Enjoy. As men's health specialists, we know guys are shaving their balls. Yeah, we examine a lot of you, so we literally see it, but we also have the data showing it too.
That's right. According to research, over 85% of men trim their pubes. Not only that, but research shows that over 70% of women prefer a partner with at least partially trimmed pubic hair.
So guys, we know you're trimming the hedges, and we know that most women prefer you manscape. So if you're going to shave your balls, why not use the best men's grooming kit around? We're talking about Manscaped.
With the Manscaped Performance Package 4.0, you get the Lawnmower 4.0 with their all-new skin-safe electric trimmer that protects your balls from getting those cuts we've all had in the past. You also get the Weed Whacker 2.0 for trimming your nose and ear hairs. And let me tell you guys, we all need to do a better job of this.
Yep, that's right. Kevin and I both have the performance package, and we really love it. Manscaping has never been easier for us. And for our listeners, we have a special promotion. Go to manscaped.com and enter promo code MANUP and get 20% off your first purchase.
Go get your Manscaped products today. Your balls and your partner will thank you. All right, so we are live here from SMSNA, and we are very fortunate to be joined with Dr. Alex Tatum. Thank you for coming on, man.
Thanks, Kev. I appreciate it. Justin, appreciate the opportunity.
Yeah, man, this is very cool. So in person, I feel always is better.
Yeah.
And, new setup for us. Thanks for helping out with that.
My pleasure, man.
Actually, Alex helped out a lot with the camera setup. As you've probably seen from our previous episodes, me and Justin have been struggling big time with it. But now it's going to look excellent just because Dr. Tatum has helped us out.
Yeah, for sure.
So look, we're going to talk about a topic that I want to personally say I don't know much about. I'm not very, informed on it. So I'm really looking forward to learning a lot about it. So let's start with the first question.
Sure.
Dr. Tatum. Let's break down the difference between anabolic steroids and corticosteroids. How are they different?
Yeah, absolutely. So, the term steroid just refers to the shape of the molecule. And so if you go back to the days of, when we were suffering through organic chemistry, you've got these, benzene rings, these little, circles, and a steroid has 4 of those, stacked on top of each other. And really it's the additional structures that are added to that will differentiate something as being a glucocorticoid, a mineral corticoid, or an anabolic androgenic steroid. And so whenever someone says steroid from a chemical standpoint, it could be any one of those things. But, practically in our modern era, you hear the word steroid, you think anabolic steroids.
Right.
Yeah.
Right.
Yeah. So for mineral corticoids, they're going to be, managing things like blood pressure and the transfer of ions in the kidneys, just to help regulate homeostasis. Glucocorticoids are going to manage a lot of your inflammation and sugar levels. And then your anabolic androgenic steroids is what causes, sexual differentiation and myogenesis and the growth of muscular tissue.
Getting bulked up.
Get swole, baby.
Yeah. So, obviously, like you said, when we're talking about steroids, people kind of always assume, and especially as men's health doctors, we're talking about anabolic steroids. So there are different classes of anabolic steroids, though. Is that correct?
Yeah, definitely. And so if you kind of further subdivide it, if you're in the world of anabolic steroids, there are really 3 main subdivisions. Really what we prescribe every single day is the classic base steroid, which is testosterone. That is what we produce naturally, both in men and women. And that is what, regulates, sex drive, libido. It was what facilitates muscular growth, fat loss in guys. But everything after that is all a synthetic compound that's been created to try and stimulate that same receptor with a little bit differential activity. And so you've got your testosterone derivatives. You've got what are called your 19-nors. Those are going to be compounds that have removal of the methyl group at the 19th location. That's going to be things like nandrolone decanoate, trestolone, or trenbolone. testosterone, and then you've got your dihydrotestosterone derivatives. So in our bodies, we've got this enzyme called 5-alpha reductase that turns testosterone into dihydrotestosterone, which is a more potent form of that compound. And then we have derivatives of that. And so that's going to be like oxandrolone, oxymethylone, winstrol, and a whole host of other compounds under that tree.
Yeah, and I think a lot of people know about DHT
Right.
and the medications that, can inhibit that, the 5-alpha reductase inhibitors. Obviously,
Finasteride, dutasteride,
Tasteride, all those. And I think I have a strong take on that. But and Kevin and I were talking about this the other day.
Right.
I'm not a fan of those medications.
Yeah. It's interesting because everyone's different, right? So you've got this, medication that you could use across 100 guys, and a lot of them would be fine with it and may keep their hair, and some guys can get really messed up for a long time, even after stopping it. So, hormones are pretty powerful, which is, I think, why anabolic steroids are interesting, because they can change our physiology in pretty powerful ways, but that can have unintended consequences.
Yeah. Exactly. On that topic of finasteride, Justin, as we're talking, like just as you said, we don't have a good predictor of if you're going to be one of those patients that is going to unfortunately have some of these side effects afterwards. Now, look, let's kind of go back. Let's talk about anabolic steroids, right? It gets a bad rep. Most of the time, they think, illegal medications that bodybuilders are taking. And, this is obviously going to be a lot of what we're talking about today. And I think it's important for our listeners to understand that testosterone is an anabolic steroid. So do you think, Dr. Tatum, there's an unfair stigma on taking anabolic steroids?
Oh, yeah, 100%. And I think especially in this, modern era where, so much is driven by, visuals and having a certain aesthetic. I mean, listen, I can't pull up Instagram without seeing somebody in a bathing suit, even if it's February, right?
Right.
And, I think that I'm like, and I live in Indiana, man. I mean, nobody. Are you kidding me? Jeez. So
Miami is a different beast.
Oh, Lord. Well, I think everyone I'm seeing actually lives in Miami. Yeah. So, but, if you're looking at it, from the female side, right, that can obviously drive, a lot of body dysmorphia and, desire for plastic surgery and interventions on those sides. But the honest to God truth is that, just about every single fitness model that you see, every single movie star is taking or using these compounds in such ways. And I can say that from a place of knowledge, although I can't name names. And so, these are compounds that are utilized that are pretty potent. And I think it's important that we improve education surrounding this, because it's something that is already permeated our society. People just don't want to talk about it.
Yeah, and I think as we're going to talk about now, people don't want to talk about it. People are using it. And because people don't want to talk about using it, they're probably not using it correctly or safely. Yeah. And that's one of the really big issues.
Yeah, I mean, we've overcome a lot of that stigma in other aspects of medicine, especially like recently the opioid epidemic.
Right.
We've moved from a place of, judging and get out of my office to, comprehending, what the intricacies of addiction are, and that these are people that, need our care, and we need to better understand what they're going through. And the honest to goodness truth, that it's the same thing for anabolics. People are taking this for a reason. We need to understand that, and we need to know what to look out for so we can keep folks safe.
Yeah. Now, obviously when we're talking about anabolic steroids, testosterone is the big one.
Yeah.
And that's one that I readily prescribe, you readily prescribe, Kevin readily gives. And we've talked about testosterone a lot of this podcast. We're going to continue talking about testosterone because obviously I think everyone wants to know more about it.
Yeah.
But how does testosterone differ in general from the other anabolic steroids that we're going to be talking about today? Because really, that's the flavor of choice for many reasons, I think. But what are your thoughts?
Yeah, it's interesting. Testosterone, I think, is the prototypical steroid because it's what your body knows how to handle. It recognizes it. We often use the term bioidentical. For estrogens, that's a totally different thing. The truth is all testosterone is bioidentical. It just depends what sort of ester it's on. So I don't care if it's testosterone cypionate, enanthate, or propionate. That's just the delivery, vehicle. At the end of the day, your body body sees it and it knows that it can convert it into estrogen with aromatase, convert it into DHT with 5-alpha reductase. And so it is something that is very predictable in that regard. However, testosterone, if you're looking at it from a muscle building standpoint, it's going to have what we would call a equal androgenic to myogenic effect. Now, that's an arbitrary determination that we've kind of made in this space. So that means that it's going to cause, about as much, let's say, sebaceous gland secretion, so potentiating acne, body hair growth, hair loss, as much as it's going to potentiate, muscle growth. Obviously, with different effects across different people based on what their genetic makeup is. But that's the base kind of like story on testosterone. The big difference between what you and I do in clinic every single day versus what's used in the anabolic context really comes down to dose.
That's a fantastic point that I want our listeners to really take from it, where Dr. Tatum's talking about androgenic effects and myogenic effects. Everyone that thinks that they're taking testosterone, you're only going to get effects on your muscles, but that's not it. You're going to have other systematic effects, such as acne or balding that can kind of occur from it,
Although I will say with the dosages, I've not seen, I have a lot of patients who are concerned about hair loss specifically. And
don't see that as much.
Right? I don't really have that as much of a problem unless you're at like really super therapeutic doses.
It's a combination of doses along with what is your genetic predisposition to androgenic alopecia. Yeah. So, the one thing we can't change in life is who our parents are.
Right.
And so you can put two different guys, on, the same dose, and they're going to respond differently. And so I think it's important to keep that in mind. So
that's a fantastic point.
Yeah.
Now, so we're going to highlight a lot of the popular anabolic steroids that aren't testosterone.
Sure.
Right? And so the most important thing that for our listeners need to know is that these medications have really major potential risks, and that most people who are taking them are not being cared for appropriately, and they're not getting them from your usual pharmacy. So anytime you're getting a medication that's not prescribed, or that medication that you're not supposed to be taking, you're really putting yourself at risk for contaminants and all that stuff. So let's talk about the first, anabolic steroid, again, area that I'm not so well versed in. So let's talk about Winstrol or Stanozolol.
Yeah.
How people take them and the risks involved.
Yeah, so stanozolol is a DHT derivative that is available in really two forms. The first is less common, which is the injectable form, which is actually an aqueous solution. It's usually in like water, and just a side note, it burns like ever living fire whenever patients inject it, and it has a very short half-life. And so injection is not the preferred method of administration for the majority of patients. They're going to opt for an oral formulation. Now, what's nice about oral formulations, like with all medicines, right? You just take a pill. It's a lot easier. The challenge is that whenever you take any oral medication, it's going to go through, what we call first pass metabolism.
That's correct.
So that means that it's going to, filter through the liver before it gets to the bloodstream. And for all of your oral anabolics, Winstrol, being one of the first ones, that's going to put a tax on your liver. And so, guys who use a lot of oral anabolics are at risk for a number of different liver diseases. They can get cholestasis, they can get fibrosis of the liver, elevated LFTs. I've even seen patients go into liver failure that are taking multiple oral anabolics. And not for stanozolol, but for another oral one, oxymethylone, Anadrol, it's actually the one oral anabolic that's been linked to hepatocellular carcinoma. Whoa. And so, you have to keep in mind that, you're going to be taxing your body with these medications. Again, you could use it for short bursts, which is why, bodybuilders will typically what's called cycle, which is take it for a short period of time. But that's because of the tax that it exerts on your body. You got to give it time to recover.
It's so interesting because one of the reasons why oral testosterone was not on the market for a while was exactly the reason you described. More recently, fortunately, they've been able to, overcome that first pass of the oral testosterone. And, we are able to prescribe it in a safe manner now orally. So, that's just to shout out there are options for people who want to take an oral medication and improve their testosterones now.
Shout out.
Exactly.
Shout out.
And I think it is important that, we do kind of differentiate, these modern oral testosterone replacement options from these, admittedly old oral anabolics that, came out in like the 50s, 60s, and 70s. None of these are new compounds. Yeah. And so, don't equate, the risk of taking oral like oxandrolone or stanozolol, Winstrol with, the oral testosterone that your doctor prescribes. It's a different ballpark. Yeah.
Yeah. I also think one thing that all these medications is there's not great data on how to properly dose it, right? It's really just bodybuilding. Yeah, it's all anecdotal. It's bodybuilders, after the last 50 years, obviously have learned stuff, but they're really learning, from my perspective and the way that we talk about it, just not to fuck up their bodies, right? Like they're trying to maximize without fucking up long-term.
Yeah.
And as we know that most of these guys, you look at the wrestlers of the 80s, you look at the wrestlers in the 90s, they're not around. Most of them are not around.
Yeah. I mean, if you look at the sports that are untested, so where, USADA has no role, it's going to be in bodybuilding. Mr. Olympia was just 2 weeks ago with the IFBB. They are tested federations, but nobody watches those because the best physiques are in the IFBB. Powerlifting, the number of powerlifting federations are untested, and then also in jiu-jitsu. And you look at what are the only sports where the average lifespan of the athlete decreases with them participating in that sport. That's it. And so, and again, I'm not saying that these compounds cannot be used safely, but in 99% of the time, these guys are not plugged in with an educated physician. They are basing it off of what they've read online, what their quote unquote coach is telling them. And I'm not saying anything against coaches. I have a coach that, is bringing me through, my, powerlifting and bodybuilding journey, but, he manages my training, right? Okay. Like we have physicians that manage medication. We've gone to school for a long time to do this and to keep patients safe. So it's important that if someone is going to make the choice to pursue this, that they get plugged in with a medical professional who can, keep them safe. The best analogy that I feel like I have for this is guys will ask me, Doc, is it safe to take anabolics? And what I say is, well, is it safe to drive down the highway at 200 miles an hour? Okay. You can do it, but if you look at guys that do that professionally, like in the Nuremberg, okay, they've got entire teams of, mechanics and engineers, and they are fucking dialed in, man. And everyone is like has a singular vision on this goal, and they're doing it for a reason. Now compare that to the idiot who gets in his freaking Honda Civic, trying to relive Fast and the Furious, going 200 miles an hour, on the highway, and guess who ends up as a red smear, right? It's that kid who just wants to put pedal to the metal without dotting their I's and crossing their T's. So again, can it be done? Yeah, but it's gonna take a lot of teamwork, a lot of care, and it's a lot, man. It's a lot.
Dude, that's awesome analogy. Yeah. Awesome analogy, for sure.
All right, so let's move on to the next one. Let's talk about Trenbolone. I don't even know if I'm pronouncing these right.
Tren. Yeah. So it's funny. Tren went from being this very kind of mysterious compound that was talked about in hushed tones as one of the most potent anabolic steroids, which it is, to becoming like a meme on TikTok.
It's all over TikTok. Tren is all over TikTok.
Which blows my mind because that's like joking about uranium. It's you've got these kids joking about going on Tren, and I'm like, that's like saying, oh, I'm gonna do a cycle of fucking cisplatin or chemo or something like that. Yeah. So a Tren is a 19-nor derivative that so it's in the same category as trestolone and nandrolone, and it kind of has this almost mythical nectar of the gods status because it is so incredibly potent, not just at building muscle but preventing muscle breakdown. So it actually has a pretty profound inhibitory effect on glucocorticoids receptors. So the reason why it is so attractive is because you can be in a profound caloric deficit and you can run tren and still put on size. So it is a drug of choice for a lot of bodybuilders going into competition. Now, the drawback is that tren was never approved for usage unless you were a French woman with breast cancer in the 70s. France that was the only place it was approved, was in France in the 70s. But it is profoundly toxic to just about every organ system imaginable. It's toxic to the kidneys. It's toxic to the liver. It will absolutely trash your blood pressure and your lipids. Something that is important to talk about is the psychiatric effect of these medications.
Yes.
We talk about how, roid rage isn't a thing with like testosterone replacement at normal doses. This is not testosterone. These are not normal doses.
Yes.
This passes the blood-brain barrier, and there is actually some data in animals that would, suggest that tren actually kills neurons.
Wow.
And so guys will develop a profound amount of paranoia, anxiety, anger on tren. You can't sleep for a lot of guys that are on it. So
if that don't scare you.
I mean,
Yeah, I know, right?
but bro, the gains.
The gains. Oh, the gains, though. The gains.
And so, but tren has become a meme, but the honest to goodness truth is that, the juice isn't worth the squeeze for a lot of people to take any steroid, even more so for tren, because you can achieve that sort of look with safer medications. The only time that tren, ever, quote unquote makes sense, which, let's be honest, it doesn't make sense, is for guys that are early in their bodybuilding career that are going right into a competition, because it can give that sort of grainy, hard look that you usually don't get until you've got more mature muscle on your frame. But again, like, what are you doing, man? I mean, how many people actually make it pro in bodybuilding? How many people actually capitalize on trading their health for $1? Right. Very, very few. There's only one Chris Bumstead, man, right. and I ain't him. Okay, and it's never gonna happen.
And you have to be genetically predisposed to 100% for all those guys. Like, say what you want about their regimen and all. There is a genetic component.
Oh, 100%, 100%. And people who have the idea that they can just go ahead and, stick a needle in their butt and then all of a sudden, come out looking like Dwayne "The Rock" Johnson. I mean, nothing could be farther from the truth. Right. I mean, these guys are absolutely dialed when it comes to their sleep, their diet, and their training, their genetics, and then you add in the anabolics on top of that, and that's how you get these Hollywood physiques, these pro bodybuilder physiques, and it's a lifestyle. So again, it's there's a lot of work that goes into it, with or without drugs.
Yeah, and I don't know. I always tell people, and I tell patients, is like, yeah, you're not going to look like that dude. That dude is getting paid $5 million for a movie role. You bet your ass if someone was paying me $5 million, paying you $5 million, I have a professional trainer. I have a professional
Every
cook.
second is being tailored.
Right. So, like, these drugs are not miracles. They're not. And a lot of it has to do, it's just going to help you achieve a goal, which lifestyle and all these other components really are always the biggest part of.
Yeah. Yeah. I always joke with guys, they're like, oh, I had one guy come up to me in the gym a little while ago, and he was asking me about, getting on some of these additional compounds. He's been on TRT for years, and he's like, oh, I wanted to add in some Anavar, some Deca, and I'm like, oh, okay, yeah, well, let's talk about that. Well, why? He's like, well, I'm getting old. I'm like, bro, like, no one's paying you to take your shirt off, okay? In fact, I'm pretty sure some people might pay you to put your shirt on. So, again, there's got to be a reason. Now, I do want to say there is clinical application for a lot of these, medications. One of my favorite examples is nandrolone decanoate. I love nandrolone because it is one of the most safe anabolics that we use. Deca for common parlance. Yeah. I think it's so hilarious, by the way, that we've got this one compound, nandrolone, that we call it not by its name, but by the ester it's attached to. Yeah. Go figure. But, Deca is long been known in the bodybuilding space to improve joint pain, especially for for, guys as they're going into a competition and their estrogen's super low because they're blocking it with AIs. And we actually really quantified that when I was in fellowship. We did a trial where we administered questionnaires to guys, before and after going on DECA. And it was really fascinating. We had some guys get off of narcotics because of the improvement in joint pain.
Interesting.
And, I have patients in my practice now, thinking of one guy in particular who is, a ESRD patient. He doesn't have any native kidney function. He's about to go in for, his transplant. And by adding in nandrolone to his regimen, all of a sudden, we've got a normal hematocrit, previously anemic, right? Because he isn't getting erythropoietin from his kidneys. So he's got, good density of his red cells, which is super beneficial going into a big surgery like transplant. And he's been able to relieve a lot of the joint pain that comes from the phosphate deposition in the joints when you've got, ESRD. So, that's a fantastic example where, by using some of these compounds judiciously, we can get a profound improvement in patients, quality of lives. You just got to know when, where, and how to apply it.
What's the side effect, the risk profile of DECA?
Yeah, so the famous side effect when you're running too much DECA, especially without a testosterone base, is DECA dick. And so DECA dick. So what's interesting is that DECA is fantastically myogenic, and so guys will put on a lot of size, and one of the telltale giveaways are going to be traps, right? And so guys who kind of get this overdevelopment of their traps, if you look at tested bodybuilding federations versus guys that are untested, the traps are one of the first things that you see, right? So that's going to be your 19 NORs are going to stimulate that. But because DECA is comparatively weak androgenically, it actually does not stimulate the transfer of calcium through the sarcoplasmic reticulum that you need to dump nitric oxide to get dilation of the penile artery. And so you're swole as can be, but you can't fucking get it up. And what's interesting is that all the 19 NORs are known for having a little bit more psychiatric effects. And one of the interesting things is that tren will push guys into some pretty some sexual interest that may be far outside the norm. We'll leave it at that.
Very judicious way of saying it.
Yeah. And DECA at higher doses can do that a little bit. And you have not seen somebody more frustrated than a dude juiced out on DECA with a little bit of depression, little anxiety, some really intense urges, and it is not working, man. So if you're ever prescribing DECA as a provider, universally, guys are going to have to be on some testosterone base in order so they get sufficient androgenic stimulation.
So as personal question, so where how are you prescribing these medications? Are these through compounding pharmacies or?
Yeah, so it's interesting. The vast majority of these agents have been approved in the United States at some point previously. So before we had erythropoietin, we had decadurabolin, we had nandrolone. Whenever we were trying to prevent, wasting syndrome and cachexia in burn patients, we had oxandrolone. And so they're not, typically used for those indications anymore, but, they're still legal.
Right.
And so compounding pharmacies can still make them. And, as physicians, we have the liberty to prescribe these medications off label, which is for their myogenic effects.
Right.
Yeah.
Now, obviously, we talked briefly about stacking these medications for temporary amounts of times. Now,
do you want me to design your first cycle, Justin?
That's what I'm saying.
Yeah. Okay. All right. Bet.
How many are most people are they doing one? Are they doing two? Are they doing three? Obviously, I can't imagine more is better in any capacity here. But you're stacking it. Are you on one for a month, then you're coming down with the DECA because it's less on your joint pain? How are people doing this?
So, there's definitely, a little bit of an art when it comes to designing someone's cycle. And so I want to step back and define some terms real fast for our viewers. So, whenever someone has low testosterone, they come to us and they get started on testosterone replacement therapy. And our goal for that is a continuous dose of testosterone that gets you to a normal level and keeps you at a normal level. And so the performance enhancement benefits theoretically are going to be minimal because you're just trying to get back to normal, which can be life-changing for somebody who's low,
Right.
but it's not going to turn you, into like, I don't know, the next Arnold, right? Now, whenever we start talking about anabolics and doing higher doses, you want to do that for a limited period of time because of the stress it puts on your body. That's what's called a cycle. And cycles can run for a number of weeks, anywhere from 4 to 12 weeks, generally speaking, would be a longer cycle. And you're going to be taking much higher doses of anabolics during that time for an effect. And then afterwards, you're going to come off. And you can either come off and go cold turkey, and a lot of people, they're going to try and incorporate some of what they might call post-cycle therapy. So you're going to be utilizing compounds that we're familiar with, like, anastrozole, tamoxifen, Clomid, HCG. A lot of people are waking up to the fact that you'll probably be on HCG the entire time they're on anabolics, but they're trying to restore that native function. Or you have guys who are just, fully committed. Maybe they had testosterone deficiency and they're already on TRT beforehand, and they do what's called blasting and cruising, where they're going to sit at baseline at a testosterone replacement dose and then temporarily amp things up, crank it up a notch for that cycle for a period of time. So that's kind of the basics of, the terminology. And then the question is, what do you take and when and how much? And so for most individuals, you can run anywhere from 1 to 3 anabolic compounds. You can do more than that, obviously. And a lot of guys are going to listen to this in the bodybuilding world and roll their eyes and say, this guy doesn't know what he's talking about. But generally speaking, kind of a well-designed anabolic cycle is going to have your testosterone base taken care of. So almost every cycle that's designed these days, you're going to maintain a testosterone base to try and make sure that you're going to get that conversion to estrogen. So you're protecting your heart, protecting your joints. Then a lot of people will add in a 19 NOR if they really like them. Not everybody likes the 19 NORs, but that's going to be your nandrolone, your tren, or your trestolone. And then people will add in a DHT derivative on top of that. And so there's a little bit, of nuance to that. So for example, if you start pinning injecting a high dose of test, and DECA, for example, you're not going to really feel that in the gym. You're not going to feel like you're on steroids for about 3 to 4 weeks for most patients. That being said, if, I gave you some Anavar, which is an oral steroid, you're going to feel that within a day or two. And so what a lot of people will do is they will use their oral to kick off their cycle until their injectables really kick in. Now, the question is, how long do you run it? Truthfully, in all instances, we're looking for what's called the minimum effective dose. So what is the minimum amount of dose to get you the results that you need with the least amount of stress to your body? So I'm a fan of shorter cycles because you're going to reduce your exposure. Because if you look at, these, charts looking at muscle gain over time, really 6 to 8 weeks, you're going to get 80% of what you would for going up to 10 to 12 in most cases. And, for most people, the juice isn't worth the squeeze to go for a prolonged period of time. So that's kind of a general, scheme for structuring your cycles. But yeah.
I don't know about you, Justin, but that's fascinating to me because, again, I commonly just prescribe just a T, all this like stacking and putting these other medications on. I'm not very well versed in.
Well, I think also, it's a lot on the provider, right? Like these are guys that are, very in tune with their bodies. Obviously, they're going to be messaging you. They're going to be calling you about every little dose. These are micromanaged, and I'm not knocking those patients. It's just they have a specific goal. It's very intense, obviously, and there's intense, as we've discussed, there's a lot of intense potential side effects, so it's fucking scary.
Yeah, I mean, it goes back to the car analogy, right? I mean, I drive a 20 some odd year F-150, man. Like, I change the oil, once every couple of months, fill it up at the tank, and that's it, and I don't think about it. But again, if you're driving, balls to the wall on a track, then you've got an entire team that's getting all these analytics, looking at brake pressure and everything else, because otherwise you're going to go off that track. And it's the same with this, because even though, let's say, I only want to take 2 to 3 compounds, in order to stay safe, you're going to have to add in what are frequently called ancillaries. So these are other medications. So for example, your blood pressure is going to go up. So a lot of people, they need to add in a beta blocker. So you're talking about adding in something like Coreg or Nebivolol, because you also need to get that sympathetic stimulation of the heart down, okay? The heart's a muscle, and you're exposing it to stimulus when it comes, or you're exposing it to these compounds. You don't want to get hypertrophic cardiomyopathy.
Right.
So all you can do is reduce the amount of work your heart's doing, so it doesn't get the same stimulus that it would as if it were working, constantly at like 120 beats per minute. So you're adding in a beta blocker. Well, that isn't going to cut it for blood pressure most of the time. So then you're going to have to add in a calcium channel blocker. If you're running a 19 NOR, you're going to be specifically at risk for the animal data for your DECA. Looks awful, but
it's mostly horse data. Am I correct? The DECA?
Mouse data. And it looks, freaking terrible, but it's been shown that if you inhibit the, RAS system, so renin-angiotensin-aldosterone system, with something like a ARB or lisinopril, ACE inhibitor, you are going to potentially prevent that. All right. Well, cool. Well, on top of that, you're taking an oral steroid. That's going to mess with your liver, and especially just even high dose testosterone, that's going to throw off your lipids. So all of a sudden, you're going to be on a statin. You're going to be on, some other like niacin or other, compound to try and, take care of that. So you went into this only wanting to take 2 or 3, and you're taking this fistful of pills every
day.
Every day.
Wow.
Sticking, 5-6 needles in your ass in a week. And so, and once you get on that train, it's real hard to get off. So, saddle up, cowboy. Is this really what you want? How bad do you want to look like that guy on Instagram?
Have you guys seen the documentary Icarus by any chance?
Oh, it's amazing.
I've watched some of it.
Bro.
So good.
Oh my God. I love it.
I love this so much.
It's fantastic.
Yeah.
Yeah.
But then just watching that, the guy who's like, I'm going to start injecting. And then next thing you know, he's like, I just got all these needles. I'm injecting my ass all the time. I'm bruising here.
Yeah. Yeah. I'll tell you though, if you like that, you need to watch Bigger, Faster, Stronger.
That's fantastic.
Dude, he's in the middle of trying to put together Bigger, Faster, Stronger 2, and I cannot wait for it.
That was such an enlightening documentary.
Yeah.
In terms of like the supplement industry, in terms of all that stuff, it's a wild shit, man. Really wild shit.
It is. But I think it's so important for us to know about this as a men's health specialist, because this is what is facing our patients.
That's right.
And we need to be advocates for them, and we need to be able to speak to them intelligently about these topics. So even if as people watch this podcast and they're like, I'm never prescribing those meds, that's cool. I'm not asking you to, but if you educate yourself, then you can speak to patients, and maybe you can prevent someone from hurting themselves, or now you know what to watch out for. Yeah.
And I just think that everything that we talked about, and we're still not done, but if I'm a patient and I'm trying to learn about anabolic steroids, and I'm like, my buddy has some trend that he's willing to sell me, you listen to this and you're like, oh fuck.
Yeah.
It's not just trend, right?
No.
Like I'm going to be on and some people are, but some people are just on trend and they don't know about all this other stuff. So then they're really harming themselves with not doing this other thing. So it's enlightening.
Yeah, I know. It's interesting. And the biochemistry is so complex because, for example, tren is not a substrate for aromatization. So that means that it doesn't turn into estrogen.
Right.
So all of a sudden you are going to be going through a lot of menopausal type symptoms because you're going to have zero freaking estrogen in your body, which we know is cardiotoxic. We know is neurotoxic. Eats your joints alive. Like, you're there under the bench and it's just like creak, 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 creak.
And it's such an interesting thing for that, because I see so many guys who have been on some kind of cycle or they've just been on aromatase inhibitor, they've just been blocked out of estrogen for years. And I don't know why, but in the community, some 5-10 years ago, it used to be thought like guys didn't need estrogen, or maybe it's in this little world that guys don't need estrogen. And they come to me and they're like, why aren't you putting me on anything to get my estrogen levels? I was like, dude, you need estrogen.
Yeah.
Man.
You do. I will say though, I mean, you need estrogen because otherwise, just as women need testosterone, men need estrogen. But again, when you're running really high doses, then you have to watch out for things like gynecomastia because it's a combination of prolactin, estrogen, and IGF-1 that can all stimulate breast tissue production. And so you want to go ahead and you have to keep that at a normal level. But this is also the problem. Like we know, generally speaking, a testosterone to estrogen ratio of 10 to 1 is pretty desirable in men. But dude, you're pinning freaking 5-6 cc's of test a week. Okay. Right. But if you let that, that ratio continue, you're gonna get gyno. I'm just throwing,
There's
and you're
a
gonna
threshold.
get water
There's
retention.
a threshold of estrogen.
And so you're gonna have to drop that with an AI, and then you're gonna get differential expression, and you're gonna have side effects from that. So, I mean, again, there's a lot more to this than sticking a needle in your ass.
Yeah. That's a great point. Now, there's another interesting drug that's often used off-label, right? These are, SARMs or SARMs. So, can you tell us about them?
Yeah, don't do them. So, if you think about it, like all of these anabolic steroids, okay, they're steroids because they've got that, 4-ring structure, all right? And we use them because they can bind to receptors and, cause this downstream activity that we're interested in. Now, the goal is, instead of putting a needle in your butt, what if we could come out with an oral medication that can still bind to the androgen receptor? And so we have these compounds. None of them have ever come to market in the United States. They are sold online as quote unquote research compounds, just the way that you'd be able to buy basic reagents for your biochemistry lab. Yep. But, they've got freaking branding on them of like a jacked rhinoceros or something. So clearly, I mean, we didn't have any of that in my lab in undergrad. And so these are going to have a lot of different names, Rad 140, Ostarine, et cetera, et cetera. And these are going to bind to the androgen receptor. And unfortunately, they are very unpredictable in their long-term outcomes. There's been a lot of data that's shown that they can be carcinogenic. You're going to get a lot of contamination in these underground labs, especially with those orals. And again, just because you buy something doesn't mean that you're getting that. And it's the most messed up guys that I have seen have been guys that have used SARMs. They've not been guys using just anabolics. And that's because the possibility for contamination and for really irregular receptor interaction is profound. I mean, we know that just by taking finasteride for a little bit, it can screw up your hormones lifelong. I mean, this can jack up your receptors for forever.
Yeah, I mean, the SARM's journey is an interesting one because, it was designed originally, just like a lot of these are things, to treat, cancer patients. I think the original study was to look at women also with metastatic breast cancer. And it was taken off. They ended the study because it just wasn't working. And then there was a point where you could actually buy a SARM, I believe, in like GNC and stuff.
Oh, yeah.
And you could buy these SARMs. And I think it was in 2007, I think they changed the law. And then since then, it's been off market and you're buying it online. Yeah. But the interest in SARMs has, I published on this, has still continues to rise because the concept of taking a medicine that specifically is signaling to your, androgen receptors in your muscle without getting the impact on your testicles or impacting your fertility, it seems like a pipe dream.
Yeah, it's attractive, right? That's you're selling a pipe dream.
But it is very much a pipe dream. And, it's funny because I've had some guys reach out to me and they're like, well, I'm interested in SARMs because, I'm kind of afraid of putting a needle in your butt. And I'm like, dude, sticking a needle in your ass is the easiest part of being on steroids. I was like, if you are not like ready for that, you ain't ready for this. Okay. Because honestly, like that little pinch is the easy part. Yeah. So, I will say, I just have to put this out there every time the topic of SARMs is brought up. People always lump in ibutamorin, MK677 as a SARM. It is not a SARM. It is a growth hormone secretagogue. It is a ghrelin receptor agonist. It is just a very nitpicky thing. So that is, if you see that, again, Don't buy it off some random place online, but compounding pharmacies can make ibutamoren, and it is good at stimulating growth hormone secretion, and it is, actually incredibly safe. So, but it gets lumped into that because it's got, a 2 letters and 3 numbers behind it.
Now, I mean, obviously all this stuff, one of the biggest things that, Kevin and I always harp on in testosterone and anabolic steroids in general is the side profile of, using it forever, pretty much. You become dependent on it and you become infertile. And, the medications that we talked about today, these are things that mostly younger guys are interested in trying.
Yeah.
I'm guessing they have the same impact. I mean,
they stimulate the androgen receptor.
Right?
Absolutely. Yeah. And, as, guys who specialize in male fertility like ourselves, we often see the guys who get tagged with infertility as a result of this. The challenge is that even if you look at the best papers, University of Miami came up with a good paper recently looking at sperm recovery rates with men that have been on anabolic steroids and given urinary HCG and FSH. That's interesting. And it gives us an idea of maybe what men can expect when they come to us with infertility. But the problem is we don't know the denominator. There's so many men on anabolics that, I know outside of medicine who have no problem getting people pregnant.
Right. Exactly.
And so again, it is something that, just because your buddy says it's not going to happen to you, or no, I had no problem getting my wife pregnant, it doesn't mean it's going to be the same story for you because of that differential expression, or manifestation in patients.
Yeah, you're absolutely correct. Like, I've had patients come in, they're like, I'm a full blast TRT. They're like, I've had 3 kids. And you're like, well, good for you.
And none of them look like you. None. Bro.
No, I mean, I think one thing that guys don't understand is, okay, I come off, I could do HCG, Clomid, FSH, whatever. The problem I have with a lot of these guys consistently is they just don't feel good. Even, and that's the worst part. The argument becomes, hey, man, I've recovered. I've been in situations where I've seen guys, they're on FSH, HCG. I put them on. They're on it for like 6 months. They're like, dude, I can't hold out any longer. They had no sperm in their ejaculate. They get sperm in their ejaculate.
Yeah.
They're like, I need to get back on this shit right away. I give them, and I say, listen, if you really are that miserable, they can't work. I put them on TRT with HCG, bottom back. It goes away sometimes for these guys. They feel better and they lose their semen. So it's not like, I mean, at some point you can go back on, but that journey for a lot of couples is hard. And I tell the female partner, like, I understand. And it's simple to say, like, get off everything. But when your testosterone's like, these guys' testicles are just burned out. And, you give them everything. They're able to make a little bit of sperm, but their still testosterone is at 75. How, it's hard to get through the day.
And, a lot of guys are it's one thing that is a big part of this equation that we can't test with our regular, blood draws is androgen receptor expression.
Right.
Like, we know that our body is going to try and go back to homeostasis. Yep. Mm-hmm. And so we put our thumb on the scale and, we douse somebody in androgen. So their testosterone's so high, you can't measure it. But, unfortunately, they're going to have down regulation of their androgen receptors. So even if they go back down to, a normal test level of 600, 700, it's never going to feel normal. Right. They are going to feel low. Again, there's just such unpredictability when it comes to the world of fertility. The Baylor team with Dr. Lipschultz is presenting some data at this meeting, actually showing that some men can stay on TRT if they go on HCG and FSH and they get sperm back into the ejaculate. But I know for a fact, having been Dr. Lipschultz's fellows, we have plenty of people that didn't work. You have to take them off testosterone. Yeah. Maybe they get some back, and some guys who just never do. Yeah. Right. And so, you really are rolling the dice whenever you start to dip your toes in this water.
So that actually leads to the whole homeostasis kind of idea. I want to ask you, because a lot of patients come and ask me that, they're hypogonadal. They're like younger, like mid-30s or something like that. They had their kids, they're not worried about that. But the question they always ask me, and I want to get your opinion on it, is like, is this a medication I'm going to stay on life? Or is this something I'm going to be able to come off of?
That's an interesting question. For the majority of men, Yeah, once you get on this, it's going to be very difficult for you to get off. I have been really impressed with some younger patients, like in their 20s, who, let's say we put them on HCG and they actually lose weight. They actually stop smoking, stop drinking, make positive life changes, which, we see in our fertility patients, right?
Yeah.
And those guys who do it for sperm and also overall health, you can see their testosterone improve. And so the low testosterone is reversible to a degree, but whenever you get to that point where you actually get on testosterone itself, you're going to suppress your natural production. And, once you're on it, you're on it, man.
Yep.
Yeah.
The one thing I always struggle with, and this is what you see all over, for a lot of these men's health clinics, a lot of these things, is this idea of optimization. And I always have a problem with that because I think that, when we're talking, like a lot of the stuff you're talking about is truly, that's optimization, beyond optimization, right?
Yes. It's performance enhancement.
Right. It's performance enhancement.
Yeah.
I don't consider myself as an optimizer. I consider myself like sorry. I think we're still good, right?
Yeah.
Anyway, so I see myself as someone who's trying to get you back to where, you're feeling good, a therapeutic level. I never understood, people are like, well, we want to get your testosterone to an optimal level. I don't know what that level is, and I don't kind of understand what that level would be, unless I'm putting you on a medication where I knew you were hypogonadal or you were symptomatic. And as far as I'm concerned, if your symptoms are cured, you're in a therapeutic dosage, I consider you optimized. Now, I don't think everyone agrees with that. I want to hear both your thoughts. I'd like your thoughts on that.
Yeah. I mean, what do you think, Kevin?
Well, I think that's tough. Again, optimal, what is that? It changes for each person, right? Each person is different. I've had a patient who comes in, they're like, my number's 650. I'm not feeling good, right? My 650. So I want to be optimized. Again, I agree with you. I have no idea what that means. I'm like, hey, you're within good range, but we're not achieving it symptomatically. I don't know. I think it's a tough question.
I also think that, but to what you're saying is, sometimes it's not testosterone, and people point their finger towards testosterone levels. Yeah. There's other things.
Right.
Yeah, I mean, full disclosure, I'm on testosterone, and I have days that I feel like garbage.
Right.
And, that's because, life comes at you fast. I've got, young kids at home, as do you, right? Yep. I mean, you don't get great sleep all the time. Right. You get stressed at work. You've got, struggles in your relationship. I mean, there's a lot that contributes to that feeling of well-being that we crave as guys. And it's, a little too convenient to point our finger at just one number. Yep. And so, when guys start coming in and they start using the word optimize and they have a normal testosterone level and they haven't been on anything, we're not dealing with some sort of more complex issue. I actually say, you know what? You're right. We do need to optimize you. What's your sleep look like? Right. What's your exercise look like? What's your diet look like?
Right.
And if you want to be optimized, let's optimize those things within our control. And so, I think that there's been a lot of miseducation out there because, again, people want a pill. In this case, people want a shot. But, with healthy lifestyle choices, you may never need to visit my clinic, or at least not till you're in your late 60s or 70s. Yeah.
I think it's a great point. And I just wanted to bring that up because I see it nonstop, and I think that, like everything we talk about, we're all fans of.
You're a director of biohacking, though, aren't you?
Right.
I think about these things, and I think that as much as we love testosterone, I love giving testosterone patients, we also know when not to give it.
Yeah.
And there is this push online for some companies that are saying, hey, listen, your levels are good, but they can be actually even better than good. They need to be optimized. And then I have those guys come to me and say, well, I'm at 2,000, I've been putting, and it's hard to come back. It's hard to pull some of these guys.
Yeah, I know, especially when they become hyper fixated on a number that can change based on the time of day. And, it's funny, if you go and you work out, dude, like if you just crush it in the gym today, guess what? Your testosterone is going to be shit in the morning. Okay. Yeah. Same if you go out and you have a couple drinks. And so this is a moving target. And I think that, it's up to us to try and advocate for whole body wellness and not just, a hammer and nail approach to men's health.
Yeah.
I love that because, everything you do, a lot of things that you're being informed on online now is basically saying like, hey, look, I'll say like physicians are, they're saying I don't need T. They say my my T's are fine. The physicians are gatekeeping. No, because, we've done the studies. We try to understand as much. And, just like Dr. Tatum was saying, maybe it's like whole body. It's not just that shot. It's not going to fix a lot of things. And, that's kind of the angle where we're coming from.
No,
Yeah. And especially we just talked about, if you are, we talked about all the side effects of anabolics. If you're coming into this with a normal testosterone level, in order to get that differential expression of, putting on size and mass and serious muscle, you're going to have to do a true anabolic cycle, which means you are really in for it. And so, I mean, I will tell patients and, guys that I know from the gym, like, look at me. Like, I am someone who is on testosterone therapy. Okay. I have unlimited access to labs. I have unlimited access to medication. I understand this better than most people.
Yeah.
And dude, juice is not worth the squeeze.
Yeah.
I'm
Oh,
just
that's
telling
great,
you, man.
man.
Like, it's just, again, I love working out. I love fitness. I love bodybuilding, but there are just, some lines that I know that I am, not willing to cross.
Right.
Because again, man, nobody's paying me to take my shirt off,
Someday.
Someday.
There you go. Someday.
I don't know, man. They got a hot tub over at the hotel. So, we'll see what happens.
All right. Well, listen, this was awesome. Any final thoughts, comments for our listeners? I mean, you had a pretty good summary right there at the end.
Yeah. I mean, ultimately, what I would try to encourage all of our listeners to do who are kind of, learning about this space, maybe they're flirting with the idea of anabolic steroids, is, instead of focusing on a singular aesthetic, instead of focusing on compounds, try to focus on living the absolute healthiest life possible. Try to invest time in yourself when it comes to getting to the gym, working out. Get yourself a coach or a trainer. Whenever you lose your health later in life, you would spend any amount of money to get that back. So why wouldn't you just invest that on the front end? And so if you do that, you actually, spend, let's say, $200, $500 on a consultation with a nutritionist. I know that sounds like an obscene amount of money to some people, but the knowledge you can get from that is going to add so many years to your life and quality to those years that your future self will thank you. So focus on health, focus on wellness, longevity, the sustainability. That's what it's all about. And, if anything beyond that, please, partner with a doctor, come see us.
Now, where can our listeners find you? All of our information.
Yeah, absolutely. So, my practice website is indymenshealth.com. You can find me on Twitter, Alex, .Tatum. I'm on Instagram as Dr. Alex Tatum, and our YouTube page is Indy Men's Health as well.
Awesome, man. This was great.
This was awesome.
This was awesome.
Dude, thanks for coming on, taking the time. We appreciate it.
My pleasure, guys. Thanks for having me, man.
We'll get you on virtually too. We'll do it virtually.
We're going to do it. Yeah, this is going to be a recurring guest.
Yeah, our listeners don't know this. We're actually going to start suggesting on some shit, and then we're going to follow up.
We're going to do Trimix injections.
Yeah. 6 months from now, he's not going to have any neck.
Let's go.
Awesome, dude. Thanks.
Yeah.